for his lecture.
A very good afternoon to everyone. At the outset, I would like to thank Team APPEC, headed by HOD ma'am, for giving me this wonderful opportunity. And without wasting any further time, let's move on to the topic of today's lecture, that is the ASA guidelines for airway management. So what do you understand by practice guidelines? Now, practice guidelines are systematically developed recommendations that assist the practitioner and the patient in making decisions about the healthcare. These recommendations may be adopted, modified, or even rejected according to the clinical needs and constraints and are not intended to replace the local institutional policies. In addition, they are not intended as the standards or absolute requirements, and their use cannot guarantee any specific outcome. So how do these guidelines differ from the guidelines that got published in 2013? Firstly, they specifically address the difficult airway management. Secondly, they differ from the previous guidelines as they were developed by an international task force of anesthesiologists representing several anesthesiology, airway, and other medical organizations. However, these newer guidelines are based on the new evidence which is obtained from the recent scientific literature, along with findings from new surveys of expert consultants, ASA members, and 10 participating organizations. They provide consideration for the development of a difficult airway management strategy, including considerations for an awake airway management. They update equipment for standard and advanced difficult airway management. They recommend supplemental oxygen administration before initiating and throughout the difficult airway management, including the extubation process. They offer non-invasive and invasive alternatives for difficult airway management. They emphasize the awareness of the passage of time and limiting the number of attempts of different devices and techniques during difficult airway management. Provide more robust recommendations for extubation. And lastly, they provide new algorithms and infographics for adult as well as the pediatric difficult airway management. So the ASA guidelines studies the airway management under these subheadings, which is the evaluation of the airway. Thereafter, you need to prepare the airway. Then you have to see whether it is an unanticipated or an anticipated difficult airway, and accordingly you will plan your management. Then you have the extubation of these patients, and lastly the follow-up care of these patients subsequent to their extubation. So to begin with, we have the evaluation of the airway. That is, before initiating the anesthesia care or the airway management, one must ensure that the airway risk assessment is performed by the person who's responsible for the airway management, whenever feasible, to identify patient, medical, surgical, environmental, and the anesthetic factors like the risk of aspiration that may indicate the potential for a difficult airway. When available in the patient's medical records, evaluate the demographic information, clinical conditions like diabetes mellitus or any other clinical conditions where one may anticipate a difficult airway, diagnostic test findings like a neck x-ray or a CT scan, which can give you an idea about the anticipated difficult airway, patient and family interviews, like you have the history of snoring, and questionnaire responses like a stop bang questionnaire can give you an idea about the anticipated difficult airway. Assess for the multiple demographic and clinical characteristics to determine the patient's potential for a difficult airway or aspiration. Also, before you initiate the anesthesia care or airway management of these patients, do conduct a physical airway examination to further identify the physical characters that may indicate a difficult airway, which may include physical examinations such as the assessment of the facial features, which may include your mouth opening, ability to prognathe, head and neck mobility, or the assessment of anatomical measurements and landmarks like the multiple distances that we have, like the sternomental distance, the thyromental distance, interincisor distance, the Mallampati and the modified Mallampati grading, even the measurements that are obtained by the ultrasound such as the skin to thyroid distance, the tongue volume, and the distance from the skin to epiglottis. So they may all help you to further evaluate the anticipated difficulty in the airway. Additional evaluation to characterize the likelihood or the nature of an unanticipated difficult airway may include bedside endoscopy, virtual laryngoscopy or bronchoscopy, or a three-dimensional printing. Do assess multiple airway features to determine a patient's potential for difficult airway or aspiration. After the evaluation of these patients, one must prepare these patients before you give anesthesia to these patients. So ensure that the airway management equipment is available in the room. A portable storage unit that contains specialized equipments for a difficult airway management is immediately available, like the fiber optic bronchoscope, the video laryngoscope, the smaller tubes, the stillate, the bougie. So they all should be available, and the other gadgets that are there in a difficult airway cart should be available. If the difficult airway is known or suspected, ensure that a skilled individual is present or immediately available to assist with the airway management when required. Inform the patient or the responsible persons of the special risks and procedures pertaining to the management of the difficult airway. Properly position these patients. For example, they might require a ramp. Administer supplemental oxygen before initiating the management of the difficult airway, and continue to deliver the supplemental oxygen whenever feasible throughout the process of difficult airway management, including your extubation. Ensure that at a minimum monitoring according to the ASA standards are followed immediately before, during, and after the airway management of all the patients. So once you've evaluated the airway, you would be knowing whether it is an anticipated difficult airway or not. So an anticipated difficult airway is basically an enemy that you know and you can very well be prepared for it. And as we all know, to fight an enemy, we need to formulate a plan, a strategy. So let us see what does these guidelines have to talk about it. So firstly, they say that you formulate a strategy based on the anticipated surgery, the condition of the patient, patient cooperation and consent, which becomes very important if you're planning for an awake intubation, the age of the patient. Again, a pediatric patient may not be a cooperative patient. So considering an awake intubation in these patients can be challenging. And lastly, the skills and preference of an anesthesiologist. A person who is not skilled to do an awake fiber optic intubation or has not used a fiber optic intubation prior in a normal individual, it will be very difficult when it comes to an anticipated difficult airway in such a person. So to formulate a strategy is very important. Seeing all these factors, you have to come out with a plan. Now identify a strategy. Now what can be your strategy? It would be based on whether you want to go for an awake intubation, or is this a patient who can be adequately ventilated but seems to be a difficult intubation, or it is an cannot intubate, cannot ventilate situation, or lastly, does the patient has anatomical features or the pathological features which point towards a difficult front of neck axis. When appropriate, perform awake intubation if the patient is suspected to be a difficult intubation and has one or more of the following, namely a difficult ventilation, increased risk of aspiration, the patient is likely incapable of tolerating a brief apneic episode, and there is an expected difficulty with the invasive airway device. For uncooperative and pediatric patients, awake intubation can be challenging. Now you proceed with airway management after the induction of general anesthesia when the benefits are judged to outweigh the risks. For either awake or anesthetized intubation, awake airway maneuvers may be attempted to facilitate the intubation. Before attempting intubation of an unanticipated difficult airway, do determine the benefit of an invasive versus non-invasive approach. If you choose a non-invasive approach, identify and prefer a sequence of non-invasive devices that you want to use for your airway management. If difficulty is encountered with an individual technique, a combination technique may be preferred, such as the use of a direct or a video laryngoscope combined with either optical or video stylate, a flexible scope intubation or an airway exchange catheter, or a supraglottic airway device when it's combined with either an optical or a video stylate, or a flexible scope intubation or a retrograde placed guide wire. So you need to take these things into consideration and be aware of the passage of the time and the number of attempts in oxygen saturation. provide and test mask ventilation after each attempt when it's feasible, limit the number of attempts at tracheal intubation or even a supraglottic airway placement to avoid the potential injuries and complications. If an elective invasive approach to the airway is selected, identify a preferred intervention at which you are good at. Ensure that an invasive airway is performed by an individual who is trained to do these techniques whenever it is possible. If the selected approach fails or is it not feasible, then identify an alternative invasive intervention. Initiate ECMO when or if appropriate and available. Now, after dealing with a known enemy, let's talk about the unknown enemy. That is an unanticipated or an emergency difficult airway management. How do you go about? So the guidelines say that first of all, call for help. Secondly, you optimize the oxygenation. Thirdly, you refer to the algorithms to be sure that what next you want to do in these patients, as this could be a situation where everyone would panic. And on encountering an anticipated or an emergency difficult airway, you have to take into consideration things like the benefit of waking up the patients or a benefit between a non-invasive versus an invasive technique of managing the airway in these subset. If you choose a non-invasive technique, like in the anticipated, the same protocol you have to follow. You make a plan. If you are facing a difficulty with an individual technique, go for a combination of technique. Limit the time, limit the attempts, maintain the oxygen saturation, ensure that the oxygen is supplemented at all times during the management of the airway. Check ventilate between the attempts of different devices. If you choose an invasive technique, it should be performed preferably by a person who's trained in doing it. Perform as rapidly as possible because time can be a constraint in such a situation. Ensure that you have an alternative technique at hand in case your first preferred technique fails, and ECMO is the last alternative if everything fails. So last but not the least is the extubation. Again, it has to be a formulated strategy, which would depend upon the surgery and the procedure. Where you're anticipating an airway edema, you might have to delay extubation. The perioperative circumstances, such as a patient who has bled a lot, you may not be wanting to extubate these patients. Condition of the patient, such as a hemodynamically unstable patient or a poor GCS of the patient, and the clinician's skill that may be not a very experienced anesthetist and he may not be very confident in extubating a certain subset of patients. So there you have to plan for a delayed extubation. Also, it says for the patient's readiness for extubation, does the patient meet the criteria of extubation? The skills of the individual to assess should also be taken into consideration. Go for an appropriate time and location. As I said, maybe you're anticipating an edema. So do you want to wait or do you want to extubate this patient and may land up in a cannot ventilate, cannot intubate situation? So again, you have to be watchful of the time when you're extubating. Location, try and extubate these patients in a very controlled environment, preferably in an OT or at a place where you have your difficult airway cart available. You have a skilled technician who can assist you. You can have an emergency help at hand. So do extubate these patients at locations in which you are most comfortable with. And the clinical merits and feasibility of a short-term use of an airway exchange catheter or a supraglottic airway device should always be considered, as these can be a very useful thing in case you feel that the patient requires a re-intubation and you already have your AEC or a SAD in situ, so you can intubate these patients through these. So you may not lose the airway entirely, you would have an edge in managing these patients. Before extubation, do evaluate the risk and benefits of the elective surgical tracheostomy. Do you want to extubate these patients, or you feel that a tracheostomy would be a preferred solution rather than extubating these patients? Do ensure that you're supplementing oxygen to these patients at every time frame of your extubation, and post-extubation do assess the clinical factors that may produce an adverse impact on the ventilation. And lastly is the follow-up care. So once you've extubated these patients, what next? So use post-extubation steroids or a racemic epinephrine when appropriate. Inform the patients or the relatives about the airway difficulty that was encountered so that whenever they go for a subsequent surgery in the past, they can tell their anesthetist that these are the problems that were faced by the anesthetist in the previous surgery, so you can avoid a catastrophe in the subsequent surgery. document the difficulty that you have faced and the management in the medical record, so it can be helpful to the anesthetist, whoever would be treating these patients in the future. So now let's just quickly go through these infographics. Okay, so we talk about the pre-airway management decision-making tool. So you have to see whether you're anticipating a difficult laryngoscopy or intubation. If not, you go for an airway management with induction of anesthesia. If yes, and you have any one or more of the following factors, such as you have a difficult ventilation with a face mask or a supraglottic, or there's an increased risk of aspiration, or there is an increased risk of rapid desaturation, in such cases, you would like to go for an awake airway management. Plan. Try and find out whether you want to go for an awake technique in this patient or you want to go for an elective invasive airway. And in case you fail to establish a tracheal intubation using an awake technique, then what are the possible options that you have in hand, considering the risk and benefits of an alternative airway technique or an elective invasive airway or an alternative anesthetic technique? Or if it is an unstable or cannot be postponed, then the induction of anesthesia with preparation of emergency invasive airway. You are trying to optimize the oxygenation, and do call for help whenever you are in an emergency situation. So if you plan for an airway management with the induction of anesthesia, make sure you have a strategy in situ. You pre-oxygenate your patient and induce anesthesia. Go for an airway management. If you're able to secure the airway, well and good. If not, then check for the adequacy of the ventilation. If you're able to ventilate these patients, then you are in the non-emergency pathway, and then you can either go for an alternative device or an invasive airway, or you can awaken your patients. However, if you're not able to ventilate these patients, then is the time for an emergency pathway. So in that case, you try and ventilate these patients either with a two-hand technique of face mask or a supraglottic airway, or you go for a different attempt of tracheal intubation, maybe using a different technique or maybe using a different hand. But at all points of time, try and limit the time that you're taking, try and limit the number of attempts, and ensure that you are supplementing oxygen to these patients and maintain a saturation. If despite all your attempts, you're not able to ventilate these patients adequately, then they fall under the emergency invasive pathway of airway management. And then in that case, you might have to go for a rigid bronchoscopy or a ECMO in these subset of patients. So this is in short about the ASA guidelines for airway management, be it anticipated or the unanticipated difficult airway. I've tried to summarize them in a crux. I hope they help you and they are beneficial for you in your upcoming exams. I'll be more than happy to answer to your queries to the best of my abilities. Thank you so much for your patient hearing, and all the best to all the exam going students. Thank you so much.
Say you're not. Say you're mute. Can you unmute yourself, sir?
Thank you, Dr. Nitin, for covering the topic very nicely and highlighting the important points like supplemental oxygenation and stress factor is very important in these cases, because ultimately, if a person who is handling the airway comes under stress during CICV or any other at any other point of time, it will be very difficult to save the patient. So time management and the decision accordingly, how to change the plan from A to B, B to C is very important. Very important in these cases. So thank you so much. So do we have any questions in the chat box?
Not as of yet. We can. The questions.
So let's go for the next topic. Yeah. Now I invite Dr. Namita Saraf, sir.
Yeah.
She's Associate Professor Anesthesia in ABVIMS and RMN Hospital. Her achievements are BCLS, CCLS instructor. She's fellowship in pain medicine, and her area of interest are regional anesthesia, pediatric anesthesia, BCLS, CCLS, airway, and pain medicine. So hand over to Dr. Namita.
Thank you, sir. Good evening, everyone. I'm sure since morning your brain has been stimulated and rekindled. Let us further stimulate your brain with this very interesting and exam going important topic, supraglottic airway devices.